Testing, testing. Testing, 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 testing.
Good morning.
Hello, guys. Hello, who's on? People out there? If
Yeah.
not, we're gonna start.
Hey, morning,
Good
everyone.
morning.
Yes. They
Made
gave,
themselves
they gave me I guess Hovig was the one who got my name. And when they pulled it out, I had for Christmas, was like, he got me this thing, and I've had it ever since. So. Yeah, Hovig, I kind of know where Hovig is. Sort of know where Merlin is. The other two, I have no clue. Interesting to find out. Hovig, I think
is.
Hovig is in UCSF.
Oh, is that right?
He's in San Francisco.
Yeah. Different. He was in Michigan for a little while.
Yeah, he was doing pulmonary. Yeah, did, procedures and sleep pediatrics in Grand Rapids. You're still just doing okay, but well, it's a part of the country that it's not as interesting as San Francisco.
Yes.
He was one of the fellows that did not have a car during his year.
That'd be fun.
That's
either
get
fun or
directly
not.
on.
No, he had no trouble. He had an Uber driver that he could call on demand. Boom, and if the guy couldn't do it, he knew 2 or 3 other guys that could pick him up. Boom. Which is what my neighbor does too, the same thing.
Chauffeur.
Yeah, sort of like a private chauffeur, and then he would use the health bus, because he lived downtown. He knew when it came, and the health bus is pretty much on time, so. Walk down it. Monthly bus pass and we'll go. Okay, well,
Riley's here, we should get started.
we have a, we have a third floor, only
All right.
2 out of 5 fellows here, so.
Get going.
Yeah,
All right. All right, welcome to today's sleep medicine grand rounds. Today we're gonna talk about a topic that near and dear to my heart, but kind of an area that's a little off the beaten path for most sleep practitioners, but an area that there is a movement afoot to sort of try and move sleep medicine into the inpatient setting. So I've had, like I said, a longstanding interest in this, and so I'm going to talk about some of the data about why we should care about inpatient sleep disorder breathing. But then this is also very timely in that, at least in EPUB form, the American Academy of Sleep Medicine inpatient task force for evaluation management of sleep disorder breathing that really focus on obstructive sleep apnea is now an EPUB. So we're going to go over that, and then I'm going to talk about how we're sort of putting that in the context of our local infrastructure of Metro, which I'm primarily running as an inpatient sleep consult service, and how that's working. And I'll give you an interesting real life example of a patient I have to see today about why this could have an impact. And I'll give you some of the data I did review, just a quick QI review of what we've done so far. So just a couple of conflict of interest that are relevant to this. I've written 2 sections for up to date on inpatient sleep medicine. One is specifically on sleep apnea to get royalties for that annually, not much, but something. And the task force, which I was vice chair of, and Rita Mayer was chair of. She was still in meetings and discussions. So we're going to talk about prevalence, potential consequence of unrecognized obstructive sleep apnea in medically hospitalized patients. That's the term we chose to use for the task force. So it's not perioperative. That's a whole separate, another different talk on that. We've run for that for a long time. And then talk about evaluation and management strategies for these patients and potential structures for inpatient sleep consult services. So why should we care about this in the inpatient setting? So as we know, sleep apnea is extremely common, but it's really common when you look at inpatients. So just as a reminder, this was probably the best, most recent, although it's now over 10 years old, epidemiologic study looking at prevalence of sleep disorder breathing out in the community. This is from the Wisconsin sleep cohort. The big caveats here, so this is the numbers you hear kicked around, 5% of women, 14% of men have obstructive sleep apnea. The big caveats here that they use an AHI 4% of 15 or greater. So this is actually a very conservative estimate of moderate to severe sleep apnea in the general population. And then, as you can see, the numbers 5 and 14% are there, but there's definitely a sort of a dose response relationship in terms of the older you get, the heavier you get, the more common it becomes. So if you're a male who's say 50 years old and you have a BMI just over 30, it's upwards of a third of them. And then if you have a BMI of 40, then over half of them will have obstructive sleep apnea, at least moderate to severe OSA. So this is sort of the background context that we deal with in the outpatient setting. But when you look at the comorbidities associated with this, and you guys all know this, that OSA is strongly associated with a lot of cardiovascular and metabolic disorders. Each column here represents a study. This is an old review from now 17 years ago. But you see how common sleep disorder breathing is in certain conditions, particularly stroke, coronary disease, heart failure. Look at atrial fibrillation, the numbers sort of settle out around half of them have OSA, pulmonary hypertension, more than half do. And if you guys recall back to the days when you're doing inpatient, at least for those of us doing adult, you hear about patients, they're staffing, and the first thing they do is, this is a 55-year-old male who's got diabetes, hypertension, coronary disease, carcinoma, AFib, and it's like, ding, 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 should be going out that they have OSA, because they have all the associated comorbidities.
But that's why they have OSA, is because of those things. That's my premise.
You think these things are causing your OSA? Okay.
It's all inflammation,
All inflammation.
all peripheral.
Well, it could be,
Even polycystic ovarian syndrome has higher.
yeah. So they could be, there's bidirectional in some of these situations, but regardless, it kind of doesn't matter in the scheme of things because the OSA is usually not diagnosed. So to look at some of these conditions specifically, this was an old review, meta-analysis of all the studies done up to this point. There's more looking at prevalence of sleep disorder breathing in patients who've had a stroke. The thought being here that the stroke is not causing the OSA, is what you think, but more that the OSA is probably, you're looking at enriched patient populations that have bad outcomes from long-term untreated, undiagnosed, untreated sleep apnea. So for some reason, the neurologic field tends to hang up on the HI of 10, so that's what they use as the definition here. But it's over 60%. And when you look at specific cut points, if you look at what we more commonly look at 5, it's about 72%. 30, so severe, it's a third of them, and only a minority have central sleep apnea. Another important thing here in this review is they also include a number of studies that looked at just TIA patients. So no permanent neurologic damage, so it's an argument against why the stroke is causing the sleep apnea. The prevalence rates are exactly the same. You had a TIA versus a stroke. So in a lot of cardiovascular diseases, so again, remember those 5 and 14%. So studies looking at patients coming in with HFrEF or HFpEF exacerbations, the numbers sort of settle out again, probably around 50 to 60% of these patients will have clinically significant obstructive sleep apnea. There's a mix, in particularly with the HFrEF patients, of central sleep apnea. The argument's always made, well, they're acutely ill and fluid overloaded, their upper airway is probably fluid overloaded, so you're getting a false reading, overestimation. But at least in Dr. Kayat's study, when he was at Ohio State, and I'll show you some more of his literature or data that he generated there. When they brought patients back, if they had OSA diagnosed in the hospital, and they brought them back for PSG 6 to 8 weeks later when they're clinically stable, 100% of them had OSA still. So arguing against that point. If you look at acute coronary syndrome, again, probably around 50% or more have a clinically relevant sleep apnea. This is Rena and Kingman's study from 20 years ago.
There's no difference in readmission or mortality at 6 months.
Yeah, we'll get to that as well. We did a study also at Metro that gets to be published. Again, it was about 55% patients acute coronary syndrome that underwent intervention during our study in the hospital at OSA. So a pool prevalence for these conditions around 50% based on this review. But also if you look at COPD admissions, so there's a little higher rate in COPD patients, the overlap syndrome, so almost half of them by this just oximetry testing at 4%. Looking just obese patients coming to hospital, extremely high rates using a HI 4%, 10 cutoff. Older patients, and then African Americans. So all these things are kind of known associations, potential risk factors, and you see very high rates when these patients are in the hospital. Again, probably looking at an enriched patient population that's having some sort of outcome related, possibly to untreated sleep disorder breathing. This is a study I did a long time ago, just looking at patients admitted to the general medical floor. So this is no risk factors, not selecting for anything. They did not come out of the ICU or step down unit. They were just admitted. We randomly selected them on the floor using sort of a random number generator. We did full PSGs at the bedside and found that 80% of them had an HI 3%, more than 5. But when you looked at the HI 3% of more than 15, so moderate severe is 42% of them. Average age was 47. They weren't particularly overweight. Average BMI was 30. And the interesting thing was that when we went back into the medical records after this, we just went up and did the studies and then kind of let them do what they want to do. Only 2 of the 88 patients to the inpatient team suspecting they might have sleep apnea. Nobody was thinking about it during the admission, which is and like Dr. Kayat's study, we could get a subset of them to come back and do outpatient sleep studies later once they were clinically stable. So most of these patients are coming in with COPD, asthma, diabetes, cellulitis, these acute kidney injury, these sort of things. It wasn't really heavily related with cardiac disease. But almost all the patients, when they came back later, you see some were a little better, some were worse. Some were about the same, but all of them that came back for outpatient studies still had obstructive sleep apnea if they were diagnosed in the hospital. So it's very common in the inpatient setting. It's also very underdiagnosed. It's also a study we did at Metro a number of years ago. This is not unique to Metro, but we just had 100 patients that were coming in for new primary care visits. And after their visit, we grabbed them at the checkout desk and we asked them to fill out some questionnaires. And 2 of the questionnaires included the Berlin as well as a stop questionnaires. We did the Cleveland Sleep Health questionnaire. We found about 1/3 of the patients would be very high risk for sleep apnea. So these are using tools that have positive predictive values of about 0.9. So most all of those patients are going to have OSA. But when we went back and looked in the medical records, see how often did the primary physician actually, bring this up, ask questions, reviews anything in their chart, anything in their note at all. There were only 2 patients where it was mentioned. One had a known diagnosis, and the others they actually suspected it. But you can see how many of these patients were being missed in just the outpatient setting. And again, not unique to Metro. There's been a bunch of other studies, different methodologies showing the same thing, kind of universally. In the United States, it's just not on people's radar. They don't have time to deal with it. They may not be aware of it. There's a whole bunch of reasons why they don't get reimbursed for asking about sleep stuff. So currently, the American Academy of Family Practitioners, the U.S. Preventative Task Force, a number of other societies, CDC, I think, recommend against broad screening of everybody that you see in clinic for sleep apnea. But the ASM does have some recommendations. So back in 2016, they published a quality QA paper about who they thought should be at least screened for sleep apnea. So they went over 18, and then a lot of those conditions I already mentioned, always cardiovascular disease, metabolic disorders. That was updated in 2024 after getting re-reviewing things and getting some public input. And the notable changes here, just AFib or any arrhythmia, it used to be nocturnal arrhythmias. They got rid of resistant hypertension, and just anyone with hypertension should be screened. They got rid of just preoperative bariatric and any other surgeries. They also include pregnancy and then symptoms and craniofacial abnormalities. So when you think about your primary care clinic, this is going to be the majority of patients that are in a clinic. So people should be screened. Now this is based on the ASM's opinion. It's not. There's sort of extrapolation of existing data.
So it's not adopted by insurance either.
Well, I don't know if insurance says if you screen somebody in clinic. I mean, I don't think they're going to say no to getting a study as long as you give legitimate reasons for it.
Right, but let's say if you only give them a reason patient has hypertension and
That's true. You do have to. So we do run
Right.
that problem a lot. So we're
Right,
screening
yeah.
our orders. A lot of our insurers require at least 2 symptoms. You can't get a PSG based on just snoring. You can't get just based on abnormal oximetry. You can't get based on just hypertension. Yeah. So if you've got to usually got to have some symptomatology.
Right.
You're right. So you're right in that regard. So it's missed in an outpatient setting routinely, and the mantra right now is about 80% of patients with OSA are still undiagnosed. It used to be 90, gotten better, but still very much missed in the outpatient setting. But it's also missed in the inpatient setting. I show you the data from our study, which suggested that patient primary care providers in the hospital aren't thinking about it. I think that's gotten a little better over time. But this is, again, a little bit older data, but again, suggesting that it's just not thought about or discussed in the inpatient setting. So this was a national 2.4 million admissions, the National Hospital Discharge Survey. 0.6% of admissions they mentioned sleep apnea at all, and 5% used capital in the hospital of those 0.6 admissions. So again, suggesting even though I showed you the data, suggesting a lot of these patients in the hospital have undiagnosed sleep apnea or potentially sleep apnea, just not being thought of. And another large multi-center U.S. study, 250,000 patients with pneumonia, 6% had a diagnosis of OSA and ICD codes. And there's problems with ICD codes, so these aren't perfect studies, but again, suggesting that this is not thought of in the patient setting. So we know sleep apnea does have consequences, certainly for the long term. And there's some data hinting, and I'll show you some of that there could be potential problems in the inpatient setting. Certainly in the perioperative literature, we know this is a problem. It's a little bit different there because the patients come in often unrecognized and they get slammed, with anesthetics, and then they get opioids, maybe sedatives, and that can create some trouble. So that's often not happening in the medically hospitalized patients, but they could. So you guys know all this, that sleep apnea has been associated, sorry about the cause and effect, but, all the cardiovascular things we talked
Chicken
about.
and egg is what
Chicken and egg, yeah.
people have done before.
Yeah, and that used to be debated a lot in stroke, chicken and egg. I think everyone's kind of gone to OSA is probably preceding the stroke now.
Yeah, but what caused the stroke in the first place? Inflammation of blood vessels over
Yeah.
10-15 years.
Yeah, but that could be related to the sleep apnea. Intermittent
Didn't
hypoxia.
20 years ago, and
Ongoing,
I know,
ongoing,
that's the question. All right,
because most of them aren't diagnosed, actually. I'll show you some of that information.
35% don't have it. Why don't they have it?
What's that?
35% don't have it in all these populations.
Oh, yeah, I'm not saying it explains everything. No, it's one of the risk factors. So it's like hypertension, right? Not all people have stroke have hypertension, but most do. So diabetes groups, you guys know all this stuff. So in the perioperative literature I mentioned, so these patients, it's been pretty well documented that they have increasing or worse hypoxemia, post-procedure, post-surgery anesthesia. And then the sympathetic activity associated with that, many of these patients coming into surgery, they have obesity, and where that puts them on the oxyhemoglobin curve, often they're very low to the knee, they're close to the knee, and so more prone to desaturate. They carry a lot of those comorbid conditions, so now you put them in the stress of a perioperative environment, and you can see how things could potentially get worse. Because of their upper airway, many of these patients are difficult to intubate, extubate. Anesthetic sedatives and opioids all have similar effects in that they make apneas more frequent and more prolonged. So by the effects they have on the upper airway musculature, they make the airway more prone to collapse. And then the response why patients don't die every night when they're sleeping with sleep apnea is because their arousal system wakes them up from these events. But these are suppressed by all these things, so they become more pronounced. So as a result of that, more frequent, more longer apneas can lead to worsening hypoxemia and increased hypercapnia in the postoperative setting. Many patients after surgery require to be on their back, so about that being worse. And then there's potential for REM rebound. So often in the night prior, night after surgery, there's a paucity of REM sleep, usually because their sleep is very fragmented, interrupted, maybe because of stress, anxiety, pre-op and post-op because of pain and medications. But then it's subsequent 2 to 3 nights later, they are prone to more REM rebound. A lot of these patients have REM prominent sleep disorder breathing, so it can get worse. If you think about the inpatient population that's medical, so not undergoing surgery, so we take out the intubation, we take out the anesthetics, we take out the required supine positioning, a lot of these risk factors still hold. So it's possible patients get sick, they're stressed, unrecognized sleep apnea, and you put them in this kind of environment, and all these things could be happening and could make things worse, which could lead to adverse events. So there's a little bit of data. It's mostly soft observational data looking at this. So this is an interesting study done by Sunil Sharma, where they looked at patients coming with acute heart failure who were diagnosed with sleep disorder breathing, obstructive sleep apnea with limited channel studies in the hospital. And these patients, some were given opioids, some weren't, as part of whatever, pain or part of dyspnea management. And you can see that when they looked at escalation of care, so meaning ICU transfer rates, it was dramatically increased in those who were given opioids compared to those who were not. So it's suggesting there's an association. So this is kind of, I don't know why they use 10 to 15 as a cutoff, but more sort of mild, moderate, and then severe sort of breathing patients. And then we know that patients who've had a stroke and are found to have sleep disorder breathing, they do have worse short-term outcomes in terms of functional recovery from their stroke, and more post-stroke depression, which is a big problem. And there is data suggesting that unrecognized or diagnosed and not treated, that they're a much higher rate in the first 2 years post-stroke to experience recurrent strokes, as well as increased mortality when you compare it to patients who don't have sleep disorder breathing and had a stroke. And this was a study we did at our place that was never published, just looking at patients who came in, had a stroke, landed on a rehab, so they're there for 3 weeks. So as part of our protocol there, we just do screening oximetries on these patients to risk stratify them. So breaking out in terms of ODI 3% quintiles, this is looking at their FIM recovery, so functional independent measures. So you expect this to go up over the 3-week time period. So this recovery from their stroke in those 3 weeks with aggressive rehab. And you see that, again, there's sort of a dose response relationship. Once you hit at least mild, probably mild sleep disorder breathing, that their functional recovery, which was lower than those that look like they don't have sleep disorder breathing. Again, just an association can clearly argue cause and effect, but there's other data suggesting this as well. So talking about readmissions, these are again a study looking at heart failure, overnight oximetry only, sleep disorder breathing predicted readmissions and mortality at 4 months. This is one of Randy Kayat's study when he did Ohio State. So for a while, when he was at Ohio State, everybody that came in the heart failure unit there got a limited channel study. So they were accumulating tons of data. This is 1,100 patients. And they could tell if these patients had no sleep disorder breathing, obstructive sleep apnea, or central sleep apnea. And then they follow these patients. They did not make recommendations based off the study. So like we did, they didn't say, put them on PAP therapy or do something else. They sent a note to the primary care saying, this patient's diagnosed, and they kind of let what happened happen. Most of these patients actually still were not treated. We look at percent survival. This is going out months after their discharge. So you can see as soon as probably 1 to 2 months, there starts to be a separation. With the blue line here being OSA and the red line being central sleep apnea, compared to those that don't have sleep disorder. By a year, there's a dramatic difference in their survival. This is using a cutoff of 15. This was a Mayo Clinic study, 100 patients coming with acute MI. They did full PSGs at the bedside like we did. They did this within 7 days post-event. They broke them out to the HI 4% and 15 or not, and they looked at MACE, so major adverse cardiac events. So this is a composite outcome, which you can kind of quibble with, but death, reinfarction, stroke, significant arrhythmia, heart failure remission. And what you can see is that the MACE probability goes up depending on whether you have sleep disorder breathing or not. This is months post-discharge, so it doesn't start to separate or appear until really about 6 months. Hypoxia was a stronger driver than the HI. We know talked a lot about the imperfect measure that the HI is, but just hypoxia seemed to be a big driver. And then you guys have probably heard about the whole association with sleepiness and cardiovascular outcomes when they reanalyze this data by subjective sleepiness, look at their Epworth score, much higher rates of MACE and reinfarction if the patients were sleepy compared to not. This data went out about 4 years.
So what was the oximetry, or hypoxia? Oh, I see.
So minimal SAT, less than
Minimal,
85%.
just like minimal.
Minimal SAT, so it's not truly a good measure of hypoxic burden, which they probably should reanalyze the data based on
Yeah, percent.
more modern,
Percent.
more modern definitions of that. And then again, Sunil Sharma looked at just rapid response. So this was just based off STOP questionnaire, almost 2,000 patients, which they were doing in some of their earlier work. Looking at a rapid response per 1,000 admissions during a 2-year time period. And you see almost a doubling in those that were high risk for sleep disorder breathing versus not. They didn't make any changes in their medical care based on their screening. Having said this, there is data, so I'm cherry picking a little bit because there's also some data suggesting no difference depending on which study you look at. These are all observational studies and generally retrospective in nature. So could treating sleep apnea, if you do identify it in the hospital, impact their outcomes? There's actually a couple of studies, actually more than this. There's 4 small randomized controlled trials, at least 4, maybe 5 now, of patients who've had a stroke, sleep disorder breathing found or suggested, and then they get put on PAP therapy. The problem with these studies are all very, very small, limited generally 40 to 45 patients. They're only looking at 1-month outcomes. Interestingly enough, though, they all showed benefits with PAP therapy. So, but the other interesting aspect is that the results that were positive were different in each study. So this study showed they started PAP within 48 hours of admission, so only 15 in each group. Actually, patients tolerated pretty well. Their anti-stroke scale was better. The more they used it, the better off their stroke scale was.
I don't suppose they have, kind of look at what type of mask they use, who set them up and stuff like that, just go ahead.
No, well, these were research studies, so this is different from like our real world. When we're doing some metro, that's the problem. You got RT setting them up with whatever,
Okay.
it's.
But there's a
These
real
were-
world study going on right now.
Yeah, so yeah, we'll get to that. But this one is a research, so you got coordinator who knows something, people that know what they're doing. This is not exactly.
63% looks not bad to me.
Yeah, and the data with PAP compliance post-stroke. So initially it suggested it was really poor. There's more recent data suggesting it's better than what we think, but it's still very good depending on the study. Then this other study, subacute randomized to PAP, or usual care, showed improved functional and motor outcomes at a month, but no change in neurocognitive deficits when you were put on PAP. Again, small study, 44 on the rehab service. We actually did a retrospective analysis of ours, where for a while we were being pretty aggressive. Patients with high ODIs, we were putting on PAP, and when we went back and looked at it, we did find that the tolerance, again, in part because it's an offsite hospital, we just have an RT over there. The patient's tolerance and acceptance was relatively poor, and we did not see a definite difference in the 3-week time period in their FIM scores with PAP versus no PAP if they were high risk by accident treated. So there's a mixed bag. So this is a Sleep Smart study that you're probably referring to. So this study unfortunately started in the pandemic, so it's been really hampered for enrollment. They're supposed to enroll 3,000 patients across the country. Is UH still involved with this?
Yeah, I'm the medical
Yeah.
adjudicator for adverse events, so.
We
Just tells you don't get a stroke.
we were involved with this and had to pull out because we couldn't enroll people. But it was pretty aggressive because you had to get a NOx T3 limited channel study while they were in the hospital. They had it predominantly OSA, not CSA. Again, that HI cut off at 10 for whatever reason. And then they have to get a run-in night on AutoPAP. So it's actually kind of smart because if they don't tolerate the AutoPAP, it's not something quickly amenable. And they don't get enrolled in the study. So if they could tolerate it, then they get enrolled and get randomized to usual care versus usual care plus PAP. They're looking at 3 and 6 month outcomes. So looking at 3 months with recovery from stroke and then 6 months from some more cardiovascular stuff. So last I heard is up to about 1,100 patients. I think they're still trying to enroll patients. It's like
Yeah, I
it's
think
50
they
year or something.
terminate early.
Yeah, our neurology chair, Dr. Sila, just mentioned that
Yeah.
we're still actively recruiting people.
So we're still waiting to, find out what's gonna happen. So hopefully this will give us an answer, but yeah, it was supposed to be a 3-year, 3,000 subject study. Bad time. So this looking again, when a Sharma study, observational non-randomized controlled data, 70 patients sleep apnea within 4 weeks of discharge started on PAP. They looked at total clinical events, which meant admissions or ER visits before and after the 6 months. So patients that used their PAP, dramatic reduction in readmissions and ER visits in the 6 months after they started it, compared to those that were not compliant with therapy. And again, going back to Dr. Kayat's study, so they did look at patients that got put on PAP. Again, they didn't drive this. This was by other patients, outside providers. So if you had no OSA, this was the survival going out in 3 years. If you had CSA or OSA and you got put on PAP, you can see a dramatic difference in those compared to those that did not get put on PAP. Again, not randomized controlled data, so you help user bias, other problems, but suggested. It's a smaller study, sort of all comers cardiac disease, type 3 study, 80% had an HI, 3% more than 5, most for OSA. Put on PAP, they looked at readmissions at 30 days, and they looked at those that were full users. So these are people, using it 100% of nights, more than 4 hours, compared to partial users, which was 2 to 4 hours a night, and then non-users. Readmission rates in those groups, 7 or 25% compared to 0 and then full users. Not randomized data. And then again, Dr. Sharma's data, looking at RT events, we looked at that earlier. They advised PAP on some of these patients in the hospital, and then they looked at those that actually used it compared to those that did not, and found a dramatic reduction in RT events during their hospitalization if they use PAP. Again, not randomized controlled data, but suggested. So sleep apnea clearly is very common in the inpatient setting, much more common is in the outpatient setting. And my the argument is that because we're looking at rich patient population who's probably having a lot of bad outcomes related to long-term untreated sleep apnea as a partial contributor, at least. It's clearly underdiagnosed in sleep apnea in the hospitalized patients. It's usually not on the radar. It's got a little more on the radar than Metro, but that's probably me honking the horn. Data are suggesting that there's some association with near-term outcomes, but the data has by and large been, observational data, and then treating it may improve outcomes with better data. So, a lot of questions: should we be screening these patients, testing these patients, and planning treatment while they're in the hospital? So all this kind of teaser information and data sort of led to the formation of this task force, which we started back in 2021, with Rena as chair and co-chair. You see a lot of people on the task force, you see those names, Johnson, Kaya, Sharma, people that have published a lot of this information. Cynthia Orbia is over at the clinic. And then Vishesh Kapoor was our board liaison at University of Washington, and Sushil was on the task force as well, and then he transitioned to board liaison once he became a board member at ASM. So the first thing we did was establish, we want to look at what randomized controlled data is there. We came with PICO questions. So you guys know what PICO questions are, patient intervention, going on C. An outcome comparative, yeah, comparison outcomes. So we wanted to look at those. So we came up with actually it was initially 7, and we kind of collapsed it to 6. So looking at inpatient screening, inpatient diagnostics, inpatient therapy, which is probably going to be PAL. Then we also want to look at, is there a role for inpatient sleep consultation? Is there any data there? What about physiologic monitoring? So in the perioperative literature, there's a little bit of literature there suggesting enhanced monitoring for some of these patients that might be at risk to try and prevent some of those complications. And then post-discharge management. So the patients we're going to look at were adults at potentially risk for sleep apnea. The outcomes we were going to look at in the comparator were not doing those things. And then the outcomes we're going to look at, you can see here a long list of outcomes. So a lot of these things you think about. So just diagnosing sleep apnea, escalation of care, readmissions, mortality, OSA related cardiovascular disease, stroke recovery, and then length of hospitalization, a lot of quality of life measures, as well as time to treatment, all sort of stuff. Symptom control, the number of PSGs. So we have 7 listed here. Again, we collapsed sort of we took out, sorry, we didn't collapse. We took out the patients with known sleep apnea on therapy at home. We made that a good practice statement, which we'll come to. Then we revised the task force instead of sleep disorder group, just to look at OSA, in large part because CSA and hyperventilation get to be a literal mess, and there's not much data on those things. We want to try and avoid those things. So we really just want to look at obstructive sleep apnea. The little asterisks are what we thought were critical outcomes, and then the other ones are what we consider important outcomes. So this is what's really going to drive the recommendations. And this is something that's a little bit different when you do these kind of guidelines, is we establish what we consider to be clinically meaningful thresholds for these outcomes. So where there's data available, for instance, what's a clinically meaningful reduction in the Epworth? That's published, there's data out there, so we use that. So you see references for some of these things. For some of these things, there are no references. So mortality, incidence of cardiovascular disease, readmission rates. So we kind of, as a group, had to come up with consensus about what we thought would be a clinically meaningful outcome in these things. So when you look at the results, these things sometimes are not statistically significant. They meet our threshold, but they're not statistically significant. So it's kind of in this little bit of a gray area, I think, when you talk about making strength recommendations on this. So this is what we came up with, roughly 1% reduction in mortality, cardiovascular comorbidities, 3% reduction in readmissions. Some of these things we just couldn't come up with anything, diagnosed OSA. So with the help of our folks at the ASM, they pooled over 5,000 studies. We had to go through all these title screening, abstract screening, and then full text screening. We ended up with 27 studies that were included for the meta-analysis and grading. So are you guys familiar with GRADE? This is grading recommendations, assessment, development, and evaluations. So it's a standardized methodological approach for trying to make a synopsis of available literature in a standardized way.
Wait a minute. Do you know what grade is? Have you ever seen it before? John? Yes. Let's see. 3 out of 5 fellows can't be wrong. No, they can't be wrong. So I don't know which one it is. Right? So this is how they look at all these things. This is what they come up when they say it's a strong recommendation, and it's conditional for most, or strong against, conditional against, there's no recommendation. So that's why those things come up.
Yeah.
Is that like the same thing on the US task force, which is
Yeah.
preventative services?
Yeah.
Oh, okay,
But,
okay.
That's
Same thing.
those guidelines use
Right.
the grade methodology.
Yeah,
Okay.
It's a method.
yeah.
So they allow for what are called good practice statements. Now these don't have to be clearly evidence-based. For instance, our good practice statement there's no evidence on it. But it's a standard thing that we all accept, and I'll tell you what that is.
Did you vote?
We voted for it, yeah. So the consensus has to be that we all agree that this should.
Or a majority agree.
Yeah. And then recommendations, as Tammy mentioned, so it can be strong for, which pretty much says you should always be doing this, it's recommended. There can be a conditional for, which says you should probably think about doing this, it's suggested, and should think about doing this for most of your patients, but you're gonna take into account a lot of different factors, which we'll come to in a second. There's strong against, which is like, you shouldn't be doing this, nobody should be doing this. And then conditional against, which means probably shouldn't be doing this in the majority of your patients, but you may consider some things, and there's areas where there's no recommendation. And we have some areas like that where we can't make any recommendation because we just don't really have any evidence or opinions on it. So the strength of these recommendations also comes from the certainty of the evidence. So this can be high certainty, which you're very confident, moderate certainty means probably true, low certainty means limited confidence, very low certainty means very limited confidence. So that's important when we come to our recommendations. We also factor in benefits versus harms. So what are the benefits to patients, potential harms? What are the patient's values and preferences? For instance, you approach your patient, do you want to do this based on this information? And these are benefits, harms. You know, most patients will accept this, most patients will consider it, won't accept it. And then also we have to factor in resource use, which becomes very important for this task force or this specific guideline. So we came up with 6 sort of recommendations. So collapsing in here, patients at risk for sleep disordered breathing at the hospital, we define what at risk is in the paper. Should we do patient screening and patient diagnostics? So we came with conditional recommendation 4. It's a weak recommendation with low certainty. So this is like we're suggesting you should consider doing this, but it's in the context of an overarching pathway for evaluation management of sleep disorder breathing. So I'll come back to what we mean by that in a second. For patients at risk for sleep disorder breathing, no sleep apnea, not on treatment, admitted to the hospital. So this could be patients with pre-existing diagnosis or patients newly diagnosed, and actually almost all the literature is on patients newly diagnosed in the hospital. Again, conditional 4, initiating some sort of therapy, weak recommendation, low certainty, again in the context of overarching pathway. For patient no OSA on treatment at home, this was the good practice statement. We just said there's no date, no one's actually ever looked at this, but we just said you should continue your therapy while they're in the hospital. There's no reason to stop it unless there's a clear contraindication. If they're on PAP and they're aspirating, you know, or their mental status is poor, or they have a big upper GI bleed or something, yeah, hold therapy. But otherwise, you should continue it. They can bring in their oral appliance and use it. You can use their Inspire. You shouldn't stop it unless there's a contraindication. So this is a good practice statement. So everyone agreed that we should do this. If you have at risk or no sleep disorder breathing and admitted to the hospital, should be having patient sleep consult service. Again, conditional 4, but a weak recommendation based on very low certainty. We did not give a clear specification for this, so I'll talk about what that means in a minute. For physiological monitoring, we made no statement. There's no data. We're really equivocal on whether, you know, should these patients require enhanced oximetry monitoring, telemetry monitoring. We don't know, so we made no statement on that. And then post-discharge management, again, we said conditional 4, weak, low certainty, no clear specification on what this means. So I'll show you some of the data that came out in these recommendations. So PICOs 1 through 3 are the screening, diagnosis, treatment. This is looking at mortality. So remember that clinical threshold of 10 per 1,000. So the important thing here is you look at the forest plot. So we actually had 16 randomized controlled trials that fit in this, but only 4 clearly looked at mortality. When you look at the summary here, it crosses 1, so it's not statistically significant. So that really weakens things quite a bit. But it ends up being, when you normalize this, about it was 14 patients per 1,000. So it crossed the clinical threshold, we thought. So this is positive, although it's not statistically significant.
And you said it was gonna be 10.
It said it was gonna be 10. Same thing for cardiovascular disease, again, crosses 1, but it was over 20 per 1,000. We said 10 was our cutoff, so that was positive. Readmissions, again, not statistically significant. Number change here was 6. When you normalize this, it's less than around 10, but we chose 30. So it does not, we don't think it, at least, you know, Aline was against, you know, readmissions that is probably going to prevent that. PICOs 4 and 6. So this is why we get these got weak recommendations with very low degree of certainty. So primarily PICO 4, the inpatient consult is based off of one study. I'll show you his thing, Sharma study. just the pre and post studies and observational, not, all those other ones I showed you were randomized controlled data. And this is a pre and post. And they diagnosed 150 more patients with sleep apnea based on having inpatient sleep consult service compared to a similar time period the year before, one patient. So it is statistically significant, but it's one study and it's observational. Positive number, I always say diagnosis, I'm sorry, 150 got studies, 130 were diagnosed. And then observational study, this was looking at, whoops. This one.
New diagnosis of the absolute risk.
Yeah, so this is a reduction in mortality based on getting put on managed as a post discharge. So overarching pathway. So like I mentioned, there are no studies looking at screening and outcomes. Just screen the patient, don't do anything with chain outcomes. Likewise, there's no studies looking at just diagnosing the patient and then not doing anything outcomes, because it doesn't make sense. If you're going to screen them or diagnose them, you should have an intervention. So the overarching pathway is that if you're going to do screening, you're going to do it with the intent of doing some sort of diagnostic testing, either in the hospital or shortly after discharge, with the intent of then intervening in some sort of therapy, which is generally going to be PAP. So that is what's kind of meant by overarching pathway. We don't say exactly how you have to do this, or the timing exactly when you do this, but it should be considered.
Thoughtful.
So without clear specification, so this is what we mentioned with the inpatient consult and the post-discharge. So really this comes into play. What providers and institutions decide to do should be based on their best judgment, their resources, and their local infrastructure. So we don't want to force places, they have 2 sleep docs and they're in clinic, at a half hour away to be coming in and have to be doing sleep, and obviously based on the level of recommendation is relatively weak. But what we do want to get people thinking about it, and maybe this is a nurse coordinator who starts to help capture these patients, or, we gave a lot of examples in the paper about what this possibly could be. It could be something as minimal as that to as extensive as having, an attending and a fellow and proactively screening everybody in office. And then
How about pulmonary medicine?
that could be an option as well. Yeah.
But is it a viable option? Has anybody looked at that?
No one's looked at that specific. And then there's lots of calls for future research. With the interest of time, I don't have time to go through, so I want to just go over some of the other factors here. With doing the consult, and just tell you about ours real quickly. So obviously a lot of calls for randomized controlled trials to look at see, do they actually impact outcomes in a meaningful way? So again, what type of service? So traditionally we had a metro, a lot of institutions are doing this. We had a sleep consult service, but it was kind of call us if you need us, which means maybe once a month we might get a call from the cardiologist, saying this, I got a 500-pounder here, is with heart failure, haven't diagnosed sleep apnea, can you come see him and get him plugged in? And that was kind of what would happen. So I call this a reactive service. So when you do this, based on the information I showed you, it's not on people's radar, it's not on their minds. So, unless you got somebody that's really attuned to this, they're not thinking about it, so you're not going to get many calls. There's also the sleep apnea sort of consult service, just focusing on sleep apnea, doing proactive screening. And I'm going to show you Sharma's study about, or how they sort of done this at the institutions he's been at. Then you can expand this to a full sleep medicine consult service where you're not just doing sleep disordered breathing, but you're also doing other sleep disorders. And you can even tackle poor sleep in the hospital. There's a whole body of literature about patients sleep like crap in the hospital. There's all these interventions you can do, changing environments. But these are big system-wide policies, getting into medications, all this sort of stuff. So these are all things that can be considerations. And there are some institutions where you have resources to do all of that. You have to think about where is it going to be offered. So for instance, how many hospitals you got? I don't know, but you can offer it in all your hospitals. You have to put it all together and do all these things. We've got 3 hospitals plus a rehab hospital. They're just focusing at the main campus. You can do it system-wide, which really could open up for a lot of work. Our targeted areas, which is what we started at, I'll talk about. But when you're talking about just sleep apnea, the high yield areas would be the cardiac units and neuro units. Focusing on those things. You can offer this service 24/7. Someone's got to be on call then. You have the resources, personnel to do that. Weekdays 8 to 5. Have pulmonary take it over. Nocturnal coverage. These things all have to be thought about. Just going to be just sleep MDs. Background training interests. Like for instance, our institution, we have a lot of people that They just want to do outpatient sleep, and that's very common and fine, and acceptable, and they don't have any interest in going in an inpatient environment, they weren't really trained in it, they don't want to do it. But some do. What's the involvement of the sleep lab gonna be? Techs and testing equipment, do you have the sleep lab on site with your hospital? RT, are they gonna be involved? Could they potentially be involved in testing and PAP therapy? They do run the PAP therapy in the hospital generally, it's not the purview of the sleep lab. But they could potentially be involved in some of the testing. Some places have got RNs involved, to do not just the education component, but also we got more and more simpler devices to do that. Collaborating services, we talk about pulmonary, cardiology, neurology, PMR, psychiatry. Got to decide, you need screening questionnaires, oximetry, which you can't formally make a diagnosis or get therapy off of, home testing, PSGs. What types of therapies, PAP therapies, obviously doing other things in the hospital are not really feasible. PAP therapies can't make oral appliances and put in spires in the hospital. Having medications on formulary, we may have medications for OSA in the future, near future, or other sleep disorders. Then transition the patient to the outpatient setting. So who's going to arrange this follow-up, the timing of the follow-up? DME companies have to be plugged in, involved with this. You got to deal with insurance requirements, make sure they follow up. Timing.
Okay. Time game.
All right, so I'm going to show you what Dr. Sharma is. So he used to be at Thomas Jefferson, Philadelphia, where he generated a lot of data. Now he's at West Virginia, and he's translated his service over there. And he published this thing. It's a very interesting read if you guys are interested in this. It's called, it's one of those How I Do It articles in Chess a couple of years ago. And it's really focused on, they were calling it inpatient sleep consult. I think it changed to inpatient sleep apnea consult service. But he has a CPCOM protocol. So they screen their patients. They're doing it broader than what we are. So they're looking all admissions, and they use their IT to help with the COPD, heart failure, stroke, obese patients being BMI over 30, and they can screen, generate the stop bang questionnaire. They use their RT in nursing to do a lot of education, and then they get either high-res pulse oxes or ASATs on these patients while they're in the hospital. And then again, RT helps to acclimatize the patients that have moderate severe OSA. They want to recommend PAP therapy, and this is often where they involve the sleep consult service. And then they do treatment adjustments based on PAP downloads and a lot of communication coordination on discharge needs. So they rely very heavily on their EMR and IT algorithms set up to identify a lot of these patients and capture them. RTs, discharge planners, and their DME.
High resolution pulse oximetry.
So it's going to be more frequent, more sensitive sampling of the oximetry signal. So
It's the buzzword. So what's the opposite of that? Right? And what happens in the hospital?
no resolution.
Yeah. And why is that? Because it's averaged every 15 seconds. So if you have a 10-second apnea. Okay.
So this was it, that data. This is what one study. So they had one consult a month. They just had a reactive service, and then once they implemented this, it's 150 consults a month. Which is just crazy.
It is.
All right.
Well, if you look at it from a system point of view.
Oh, yeah.
That is $330 cost.
Yeah. No, it can get crazy. So I sort of took all this after reviewing all this stuff and implemented into an algorithm at Metro, kind of came up with this with our local infrastructure and what might work. So I'm gonna just run through this briefly. I know it looks like a lot, but it's not that bad. So I'm looking just in our step down unit. So it's a 14-bed high acuity unit. Patients can't be on ventilators for trade, but they're not on pressors, not on vents, and they're really sick. They can end up here. So I don't involve myself in known OSA. My colleagues can take care of those patients. If they have a question, they can call us. Obviously, if they're on a ventilator or trach, we don't deal with them. If they're comatose, delirious, advanced cancer, really old, these are patients I'm not going to involve in the screening. And I have a nurse coordinator that helps with reviewing charts. So every day I go in and review their charts, new admissions. If they have known OSA, we leave it to RT and the team to manage this. If they have questions, they'll call. We do a stop bang on everybody else. If they're stop bang 0 to 4, this is my twist sort of. I order an oximetry on them once they're stable. So on 2 liters less oxygen, otherwise clinically stable, not getting a bunch of sedatives or alcohol withdrawal, whatever. And if this is abnormal, more than 10, then I will ask them to put in a sleep consult to go and see. If it's less than that, I consider a double negative. and we don't involve ourselves. There are some where it's kind of 5 to 10, stop banks 3 or 4, I may say in the report, probably think about getting a sleep study on this patient later.
That's the oximetry interpretation.
Oximetry interpretation, I put that in.
Hey,
No, I'm doing this pro bono. And I'm gonna show you a real life example here at the very end about why that pathway, why that's important. And patients who have stopped bank 5 or more, so the literature suggests these patients are at high risk for moderate severe sleep apnea, right? So the majority of them can have moderate severe sleep apnea. So if that happens, it will trigger an inpatient sleep consult. So I will go see the patient, I will discuss with them. It doesn't take that long, I ask them questions about sleep apnea, some other just sleep questions. I discuss with them about what sleep apnea is, how we can do limited channel testing in the hospital. And if they're agreeable, then we go ahead and get it done. So if their HSAT shows an REI 3% more than 15, then I will consider putting them on PAP therapy, depending on circumstances, and if they're giving them to stay in the hospital. If it's less than 15, then usually I'll recommend outpatient follow-up. And then we get them plugged in. So our nurse coordinator plays an important role in helping to track these patients in the system, getting them scheduled for appointments, make sure. And I'll order the PAP. So the reason I do that, if they're negative on the stop bang, the oximetry is a double check. So this was from our study of the inpatient setting. So we know one of the big problems with all the screening questionnaires, negative predictive values are relatively poor. They have very good positive predictive values, but their negative predictive value specificity is relatively poor. It's even worse in the inpatient setting. So that when I did PSGs on those 88 patients, we did all these questionnaires on them as well. And you can see the negative predictive values are horrible, they're 30% or less. So these patients could still have sleep apnea. So I'm going to show you again that example in a second. So I've been doing this for about 6 months, sort of as a pilot and step down unit. I haven't gone into our cardiac unit, but the word's getting out, so we're starting to bug me. But screening all those patients will take a lot more than I can do right now. So we average about 3 to 4 admissions a day to this unit, 530 roughly unique admissions, of which 220, so 40% were excluded during the screening process. Of the remaining 300, some didn't get screened. Sometimes the nurses don't bug them. This was particularly early on. They weren't in the habit of doing it, but most are now getting on a routine basis. So 60 of the patients ended up with a stop bang of 5 or more. 25 promised rapid turnover at these places, so you can't always capture them in the hospital. So 25 just did not get done. 4 refused, and we only had 2 failures. Of the remaining 29, we had 21 wash paths and 8 apnea links. You see the majority of these patients, 23 were diagnosed with moderate severe OSA. And then we had 129 patients had stop bangs in the 0 to 4 range. Still 15 of those patients had ODIs 3% more than 15, suggesting that they probably do have pretty significant sleep apnea, despite the fact that they scored low on the stop bang. So this resulted beyond these patients, 32 additional PSGs were ordered and 62 clinic visits. So include that the testing and the PSG diagnosis, it's roughly somewhere between 19 and 21% of the admissions that are eligible for screening probably have unrecognized and hopefully will be diagnosed with moderate severe sleep disorder. So you could argue, well, just do this, well, like just get it as an outpatient. Well, I'll tell you, my colleagues step down the unit are not asking, they're not thinking about it, these patients. These patients have been missed for years and years and years, and no reason to think they're going to go back to the outpatient environment, someone's going to take them. We're capturing these patients. Now, the big question, which I haven't had a chance to analyze, is how many patients are actually coming back to the clinic or coming back to the PSG. So that's really kind of where the money is for all this too, for various weeks. So on today's to-do list for me, says I went over to stop the metro this morning, looked things quickly. So this is a great case of why it happens. 75-year-old male, hypertension, paroxysmal AFib, coronary disease, had MI, cabbage, cardiomyopathy, pulmonary hypertension, came with a GI bleed, so multiple GI bleeds. GI saw him, he was admitted Sunday night, I think, or I think it's Sunday night. GI saw him and said, we're not going to scope this guy with a GI bleed because he's had 2 cardiac arrests after his past EGDs. So what's his scream? This is screaming this guy has sleep apnea. I'm sure he probably got oversedated. It's probably sleep apnea. But no, he's 75. No, I searched his chart. There's no mention of sleep anywhere in his chart. Why? His BMI is 21. So no one's thinking about it, right? Oh, he's a skinny guy. We have sleep apnea.
He's not Asian, is he?
but he's not Asian.
Yeah, my 21 agent.
I see a lot of thin Asians.
I see that.
But he's not. And his stop bank's only 3. He got points for his age, gender, and hypertension. That's it. So I ordered the oximetry on him. Stop bank's low. This is his oximetry.
Boom.
So his ODI is like gonna be around 25 or so. So this guy clearly has probably severe sleep apnea. I'm sure this is underestimated. But nobody's thinking about this.
Low saturation.
And he's got a low baseline sat, and then he's having recurrent salt. I can't blow this up, but he's having recurrent
Yeah,
salt.
yeah,
So this is probably why this guy's arrested after his endoscopies. So, theoretically, you get this guy tested on treatment. It could impact his cardiovascular outcomes. And, it could make him theoretically safe to undergo endoscopy or safer. So anyway, so this is kind of what we're doing in Metro based on the information. All right, so go finish just about on time.
good.
That was your inpatient.
Stop share. Or just-
Yeah.
Yeah,
Uh,
see what
You
you
gotta
have to say.
move, sorry, Dennis, you gotta move to the other screen, so move your cursor to the right, and then you're gonna see your cursor blowing up on that
where am I
top
going?
thing. Or to the left. Sorry,
I send and show.
sure, yeah, that, alright, that can, yeah.
Alright. No, he
Perfect.
turned the whole thing off.
No, he didn't,
Oh.
he's just like over there on the server screen. That's-
Nice,
yeah.
Okay,
all right.
so good morning. Keep us still recording. Great around see me. Number too small to say effective due to CPAP, too much variability. Yeah. There actually is data on the stroke outcomes. We did look at some other stroke outcomes that was statistically significant. The strongest literature in the randomized controlled trials, which I didn't have time to go into, is for the post-stroke patients. But the numbers in the studies are not huge. That's why the SMART study is being done.
And I think the outcomes are variable in terms of the endpoints used, right?
What's that?
I think the endpoints had varied between the studies.
Yeah, that was part of the problem. Some use the Rankin score, and some use a bunch of different things. It was hard to do a meta-analysis because of the outcomes.
Thanks for addressing that. I think what we've noticed on the stroke service is that probably people who have pre-existing sleep apnea who were never diagnosed now come in with a moderate stroke with an encephalopathy related to the stroke, and they get sleep deprived, and they are like unarousable during the day. They can't participate in therapies.
Yeah.
And then they're up at night with, getting a bath and getting labs, and they never make any progress until RT puts CPAP on them, and they really get a restorative night, and then they're so much more alert the next day. And I think that we should be doing this a lot more in the hospital. I just wish that not everybody qualifies for Sleep Smart, but I find that it's a dramatic difference. Not because it's making the stroke better, it's making them more alert so that they can participate and be testable.
Yeah, I agree. I think one of the biggest problem, I think, in a lot of institutions, just the resources, the personnel, the equipment, to be able to do this on a routine basis. But if you can get that infrastructure in place, I do think it